And the title of his presentation is Hepatic Arterial Patterns and Variations Using CT Data Visualization Software to Decrease Procedural Complications Due to Hepatic Arterial Variations. Go ahead, Chris.
Hi, everyone. Thank you guys for coming. My name is student Dr. Krueger, and today I'm going to show you guys how to use CT scans to make 3D models to map out arterial variations. So why is this important? In a study done by the Annals of Surgery, general or gastrointestinal surgery are actually the most common type of operation associated with errors, coming at 31%. Just for reference, the next highest type of operation is spinal surgery. That comes in at 15% errors. Of these errors that were reported, 17.25% of them were associated with difficult or unusual anatomy. So theoretically, if a process could be made preoperatively, you could eliminate almost 20% of surgical error if the surgeon could see the anatomical variation before they get inside the patient. So this is an idea of what you could be looking at. So it clearly shows the liver, pancreas, and all the blood vessels, and I'll go through one of these a little bit later. So in order to classify, I use a CRL classification system, and I use the common right and left hepatic arteries, and I was concerned about where they branched off of. I was also looking for any accessory arteries, and an accessory artery is an artery that is an additional artery supplying the same vascular area, and a replacement artery is an artery branching off the place you weren't expecting it to. From there, we would classify into different types. If we look over, one second, let me get that laser pointer. If we look at type 4 here, I'll quickly run through how you read this. So the C and the R have no subscript, so we know that these are normal branching variations, whereas the L here has a R, which means that our left hepatic artery actually has a replacement. And if we want to be more specific about where it's coming from, we could place an S afterwards if it came from the superior mesenteric artery, for example. So here are my results. I had 19 type 1s, which is normal, which makes sense, and then a handful of other variations, and I had one unclassified, which I'll go over in a second. So here is a normal. If we start here, I started with the celiac trunk, and I found the splenic artery that shoots off here. The left gastric comes up here, and here's our common hepatic artery branching off the celiac trunk, which is normal. Gastroduodenal drops down, leaving us with the proper hepatic and the left and right hepatic arteries as well. So once again, this is normal. This is the type of branching pattern that I was looking for. And then here is the unclassified version. So if we read this as the common hepatic is coming off the superior mesenteric artery. So if we come down here at the superior mesenteric artery, here we see our common hepatic with our gastroduodenal would be coming down here, but it didn't segment out in this image, unfortunately. That leaves us with the proper hepatic artery right here with our right and left hepatic arteries, and I call this here an intermediate branch. If we continue reading this, the right hepatic artery was normal branching, which is what we saw over here, and the left hepatic artery also had an accessory branch branching off the left gastric artery. So if we come back to the celiac trunk here, we have our splenic going off here, and our left gastric coming up here, and here it is heading to the stomach. And then we have this branch up here, and it's hard to tell, but this is actually entering the liver on the posterior side and supplying vasculature to this area. So these two arteries here are actually sharing it. That's why I'm calling it an accessory artery. From the study that made the CRL classification system, they compiled 2,500 patients and classified them into their system. And they found that 99.8% of their segmentations fit into the classification system. So then I compared my data with their data using a chi-square value, and I got a p-value of 0.0008, which is very significant, and that's due to my unclassifiable variant. This makes sense because according to the study, only 0.2% of segmentations should be unclassified, and the fact that I found one in my relatively small sample size, it makes sense that my p-value was so significant. I also ran the chi-square again without the outlier to see if my other data followed normal variation patterns, and I got a p-value of 0.59, indicating that they do follow the previously reported variation patterns. Future of what I want to do with this, next year I'll be starting my third year clinical education. So I'm hoping that I can present this research to my clinical faculty next year and hopefully find a way that this could possibly be implemented so we could cut down some of the surgical errors that I talked about previously. I'd like to thank KCU for setting up the research or the summer research fellowship, and also like to thank Dr. Withnell for all of his help. And does anyone have any questions?